It's a topic which is very rare that you see in your practice, but you will come across such cases. And whenever you have a patient who presents to you with an hyperextended knee joint, you have to start thinking whether this is a Charcot joint. So this was an originally described concept for an arthritic sequelae of syphilis. It is a considerable challenge because of variety of factors that I'll talk about. It's a combination of sensory, motor, and autonomic neuropathy. And more often in today's day and age, it is caused by diabetes. And diabetics nearly make 30% of our patient population in a knee replacement practice. What was the thinking for many years was you should avoid arthroplasty at any extent. Everybody thought if you do an arthroplasty for a Charcot or a neuroarthropathic joint, it is bound to fail. But arthroplasty has shown it increases patients' results significantly if you choose the right patient and you use the right technique. So we will talk about how to choose that right patient. There is significant joint destruction and instability which is present in these patients, and you will see the X-ray findings quite clearly. What is the pathophysiology? There are two theories, believe it or not, French theory and a German theory. So what is the French theory behind the pathogenesis? There is osteopenia which is associated with the Charcots because of autonomic dysfunction, and because of this autonomic dysfunction, the blood supply to that affected joint is significantly increased because of the decreased sympathetic tone and damage to the trophic centers, and that causes that osteopenia to begin with. And the German theory implicates trauma as the underlying cause. There is decreased nociceptive stimulus coming from the injury itself. There is ongoing activity and microtrauma which leads to joint and ligament damage, which actually further invites an inflammatory response, and that inflammatory response with the cytokine release will lead to further deformity through bone resorption. But these may not be true. The French and German theory, probably a combination of theory, because of sensory, motor, and autonomic neuropathy is the reason behind this gross destruction of the joint. The sensory neuropathy, as we've seen, decreased sensation, proprioception, and reflexes will lead to damage from undetected trauma. The motor neuropathy is because of the decreased support of the joint, muscular support, and the autonomic will increase the blood flow leading to resorption and subsequent osteopenia. What is the etiology? The classic description was for tertiary syphilis, but that's nearly not seen anymore. Leprosy, alcoholism, syringomyelia, lacunar infarct, cerebral or cerebellar atrophy, but the commonest, as I've said, that we might come across is diabetes in our patient population. The distribution of the joints which are affected by these diseases is different as well. If you consider syphilis, it affects the large weight-bearing joints such as the knee. Syringomyelia, as you know, is mainly in the upper limbs, and diabetes mainly affects the foot and ankle. The Charcots is classically seen in the foot and ankle, but there is approximately 7.5% chance in diabetics, in long-standing diabetics, that they might undergo these neuropathic joints. What are the signs and symptoms? Classically, a Charcot's joint is being told to be a painless condition. However, these patients commonly present with pain and instability. So it's not true that it's a painless condition. The pain is worse on walking and obviously not there on rest. And the one thing you need to understand is the degree of pain does not correlate with the destruction of the joint. So the joint might be completely destroyed and the patient says, I have some minor pain. The second problem they present is with instability. There is decreased proprioception, so the range of motion is beyond normal. There is ligamentous laxity, and with further joint destruction, the laxity will worsen as well. The signs and symptoms, obviously loss of tendon reflexes, and there are stages for the Charcot's disease. There are 3 stages. If you see the patient early in the disease, it's like an inflammatory response. There is edema and joint temperature which is raised. And you will see a strong pulses, red hot edematous joint. And the next 2 phases are the coalescent and the reconstruction phase. The radiological appearance classically is for subluxation, fragmentation, new bone formation in the soft tissues, and bone destruction. But if you see the 3 phases which are described radiologically, the development phase will have acute destruction and periarticular fragmentation with the clinical signs of redness and hotness. The coalescent phase will have bony debris which is absorbed and the sclerosis will be seen. And in the reconstructive phase, you will start seeing the body's attempt for fusion or stabilizing that knee joint with extra bone formation. But the classic appearance is histological. If you send the synovium for a histological analysis, you will see fragments of bone and cartilage which is embedded within the synovium, and that's probably a diagnostic gold standard. The non-arthroplasty and management, we all know the total contact cast, the bracing, plastering, non-weight bearing patients. But two things which have come up is the low dose, the bisphosphonates and the low dose ultrasound. And there are some RCTs which have done that if you give bisphosphonates to these patients, the bone turnover will go down and the symptoms are better as well. Arthrodesis is the classic treatment, surgical treatment which has been followed, but it should also be done after the destructive phase has radiologically ceased and you have seen evidence of sclerosis and bone formation. Total synovectomy is crucial. If you don't do total synovectomy, most of the blood supply will be stolen by the synovium around the joint, hampering your union at the arthrodesis site. What about arthroplasty? That is what we are here for. The success of arthroplasty in this condition depends on three things: the degree of destruction present, the phase of the disease, and the underlying cause of the disease. If the phase of the disease, if you catch it in early phase and do a joint replacement, it will be a problem because the destruction will continue and you will get more periprosthetic fractures and problem. And we've discussed the staging. If you see that there is radiological signs of healing or callus formation or new bone formation, you can consider that this is a coalescent or a reconstruction phase and go with arthroplasty. Underlying cause of disease, if there is a condition like syphilis and if you do a joint replacement in them, these patients later on develop ataxia as well, and these ataxias will lead to destruction of that joint with further problems for that patient. Arthroplasty has shown that there is excellent pain relief. And the last thing we did not discuss was the degree of destructions. It's a no-brainer. So more the destruction, more the problem. Earlier you catch them with less destruction, results are much better. Significant improvement in pain relief, significant functional score improvement. If you get them aligned well, they will not fail. The destruction and the instability will be less. And there is reduced need of rest, non-weight bearing. There is decreased bone loss as compared to arthrodesis, and you can still convert it to arthrodesis. Complications are horrendous. Nearly 50% complications are seen in some of the largest series of Charcot's. Dislocations are seen in 7%, DVT is in 8%, periprosthetic fractures again in 7%, and nearly 15% risk of revision surgery in the short to medium term. Counseling for the patient is important. You need to tell them the problems, the complications, and the risks associated with the operation. You need to continue antibiotics for a little bit longer period and DVT prophylaxis as well for a longer period. The deformity, bone loss, and ligamentous instability has to be tackled depending on what defects, what kind of instability is present, and complete synovectomy is necessary as well. Two conflicting thoughts, Parvizi and Kim. Parvizi warns that if you use a less constrained device, you are going to subject that patient to failure. And he thinks they might develop instability requiring revision. And he has a low tolerance for using long stems and using a constrained device. Whereas Kim from Korea warns against using highly constrained prosthesis. He thinks that there is increased stresses on the cement and bone interface, which will lead to problems and failures and revisions of these constrained implants, because you've taken a chunk of bone, you might not be able to achieve arthrodesis in the later phase. So in conclusion, we are seeing growing number of diabetic patients, so you need to keep your eyes open to understand or see the symptomatic neuropathic arthropathy increasing. Make sure that the destructive phase of the disease has ceased. So you need to make sure, check the inflammatory parameters, clinically examine the patient, see the x-rays, and once that phase is concluded, only then you should go ahead and counsel your patient. Alignment and ligament balancing is what we've been talking continuously since last couple of days. It should not, the Charcot joint should not be considered an absolute contraindication to surgery if you select the right patient and use the right technique. Thank you.